If you were wondering if the Alberta hospital system is in crisis, wonder no longer. This morning, September 21st, Municipal Affairs Minister Rick McIver sent a letter to the federal government requesting two things. One is airplane support, support to move critically ill patients out of Alberta to other hospitals in other provinces, and also for the federal government to help with ICU registered nurses and other equipment in the ICUs. This is an extraordinary measure. I'm going to talk to Dr. Neeja Bakshi of the Royal Alexandra Hospital in Edmonton. Welcome to the interview, Neeja.
Thank you.
Okay, look, let's get right to it. How extraordinary exactly is this, and what does it mean for, physicians in hospitals like yourself?
I probably speak for most physicians, probably most Albertans, that this is not surprising given where we've been going in the last weeks. I think it's a little late, to be honest, but it is also extraordinary, as you said. Never in my career, and probably many of my colleagues' careers, have we had to look at a crisis and ask for help outside of our borders, asking for equipment, asking for how we can transport patients out. And we know that we are in dire shape, that we have to get there.
And my understanding from talking to COVID-19 modelers is, cases, infection rates are expected to go up. Is that your sense in the hospital?
Yeah, certainly. And we know, we've been talking about this whole pandemic, that hospital is lagging. So we're still seeing continued growth in the community. We're still seeing transmission in the community. Certain parts of Alberta worse than other central and north particularly. But we're seeing exponential growth still in transmission, and we haven't even begun to see those hospital cases yet. Things that we're seeing now are from 2 to 3 weeks ago, just before the provincial mask mandate. So we're still going to see increases. We're still going to see capacity challenges, and we're really at a dire situation right now.
So tell me what this means on the hospital floor. Does it mean that every ICU bed is full? Does it mean that patients who need to get treatment are not getting treatment? Does it mean you're already there, or you're getting close to triage protocols?
A hybrid of all of those things. So number one, we are certainly to surge capacity. I don't know the exact numbers for today, but we are certainly in extra ICU spaces that we never had before. And there is a limit to how much we can surge. It's not so much the physical space, as we've been talking this entire time. It's the staffing. It's the ability to have the right skilled professionals in the ICU to take care of these patients. In terms of people not getting care, well, we know surgeries are canceled, so people are not getting care. And, we don't necessarily need to call that triage, but it is a form of triage in that we are saying that we need to divert our resources to intensive care unit. Therefore, this subset of population is not going to get the care that they need at the time they need it. And we're also seeing on the non-ICU wards, so the medicine wards, particularly where I work, we are seeing critically ill patients that normally pre-pandemic would be in the ICU. They would be monitored closely, but because we don't have the space, we are saying, okay, if they don't need to be on a ventilator, they can stay on the ward until such time they need that ventilator. That is not normal. That is not something that we're used to, but it's something that we have gotten used to in order to keep the space in the ICU for those who really, really need it.
Now, I've been seeing social media comments from doctors and nurses saying that they don't work in the ICU, but they're being asked to do shifts in the ICU. And they've said very bluntly, I'm not experienced at intubation, for instance. Is that a concern of yours?
Yes, I mean, from a physician lens, we have still a lot of support with our anesthesia colleagues and other physician supports that can do intubations, that can do some of those skills. But when we talk about the day-to-day care of what an ICU patient requires, it requires significant skill to know the types of medications, titration of medications, what warning signs to look for if a patient is deteriorating. And you can't teach that overnight. That's not something that you can learn, no matter how skilled a nurse might be in their own field. If you haven't done it, or if you haven't done it in 20 years since you were in training, you're not going to pick that up overnight, particularly in a stressful situation.
Well, Dr. Bakshi, how bad is it? Give it on a scale of 1 to 10. Where are we at?
15. We're not in a good shape. If we're asking for federal help, we are already saying that our resources have a finite point, and we know that. And the fact that we are here and truthfully probably should have asked for this help days ago tells us that we are in really severe shape, and we do not want to enact the triage protocol. But we're socializing it, and we're teaching people about it because we have to be prepared, and it's not something that we want to be doing.
Well, good luck to you and your colleagues, and all the best. And hopefully we don't have to have another interview like this in a few days or weeks. Thank you very much.
Thank you.